Dr. Volkow is the director of the National Institute on Drug Abuse at NIH, the National Institute. This is the world's largest supporter of research on the health aspects of substance misuse and addiction. As a research psychiatrist and scientist, Dr. Volkow pioneered the use of neuroimaging to investigate the effects of drugs on the brain, documenting how drug-induced changes in the dopamine system affect the functions of brain regions involved with motivation, reward, and self-regulation. Dr. Volkow has been named one of Time Magazine's top 100 people who shape our world, one of Washingtonian Magazine's 100 most powerful women, Innovator of the Year by U.S. News and World Report, and one of 34 leaders who are changing healthcare by Fortune magazine. So we are very, very fortunate to have Dr. Volkow here today.
Thanks very much. Good afternoon, everyone. It's a pleasure, and thanks for giving me the opportunity to come and speak with you. It's actually one of the main challenges, I would say, that we have ever had in the addiction field. And this is actually reflected not just in the number of people that are dying from opioids in our country, but how difficult it has been to actually overcome. And what makes it particularly challenging is that the opioid crisis was initiated by prescription of opioid medications that have a value. Opioid medications are the most potent analgesics that are currently available to humankind and have always been. And as was commented just now, they can be life-saving. So if you've ever been in a situation with intense pain, if you don't properly manage it, that actually can lead the patient to die. And when you are dealing with situations of chronic severe pain, if you do not handle it, it can have devastating consequences, as a very sad story that we just heard exemplifies. And so this happened, the crisis happened because of two phenomena that were occurring in the background of our healthcare system. On the one hand, I think that the lack of attention at all in advancing the science and the treatment of pain itself, even though we were aware that we needed to recognize it as a fifth vital sign, we did not at the same time advance its training, education, or the development of alternative treatments that could help patients suffering from pain. So that was one side, the neglect of pain overall. And on the other side, it had to do with the neglect of addiction and the concept that overall the addiction has been seen socially and in the healthcare system as just choice behavior. And therefore the healthcare system never really has taken upon itself the responsibility of screening and treatment for addiction, even when the data was showing that it's a disease, it's a chronic disease of the brain. So this neglect, both on the side of pain and on the side of understanding addiction as part of healthcare, is what led the crisis to emerge. And since its emergence, of course, it has metamorphosed itself into ways that were unpredictable in many ways. It started with prescriptions of opioids, and as patients became addicted to prescription opioids and they couldn't get their medications, some of them started to use heroin. Heroin came from Mexico with a very high purity, very low cost. And then around 2016, 15, we started to see that heroin was being laced with synthetic opioids with an extremely high potency. And these two other curves, from prescription opioids to heroin to synthetic opioids, has led feeding the increases in mortality that we're seeing with overdoses. And understanding the phenomena is fundamental, because if we don't understand it, we're never going to be able to control it, since it's morphing so rapidly, but also we will not then be able to prevent it in the future. And so I want us to start by owning the responsibility of the crisis. The healthcare system basically became complacent in the way that they were prescribing opioids. And again, in medicine we go, and we have historically with opioids gone from one extreme to the other. Opioids are basically extremely dangerous, or opioids, don't worry about it. If you have pain, you're not going to become addicted. And don't worry about overdosing. If you're tolerant, you can increase the doses. And we go from one into the other, when the reality is much more complex than that. Opioid medications, I'm going to reiterate, can be life-saving. But we have to recognize that opioid medications are highly addictive. And so we need to actually be able to figure out who is at risk and how to properly prescribe them without actually increasing the likelihood that a person becomes addicted. That's an aspect. Another aspect that we also need to recognize is that opioid medications, even if you have tolerance at very high doses, carry the risk of overdoses, and we need to be mindful of what are the risks associated with it. Importantly, we have very efficacious medications for the treatment of opioid addiction. And so we need to understand who will benefit from them. And thereupon comes why it's so extraordinarily important to make this distinction and make everybody aware of the difference between dependence and addiction. It's not just a theoretical curiosity. It has direct practical implications that can actually going to affect the outcomes of patients. Physical dependence is actually something that occurs to almost every one of us if we are given opioids repeatedly. But it is self-sustaining. It's basically you stop taking the opioids and the symptoms slowly disappear. Addiction is a much more rarer event. It occurs in opioid addiction, perhaps between, say, 10% of people that get exposed to it will become addicted. And it's much harder to treat, and it's much longer lasting. So understanding this, that's why it becomes so very, very relevant. So what do we know about these two processes? Well, let's start to say, why are we even here? We're here because we have been using that term dependence indiscriminately with addiction. If you look at it from the perspective of what pharmacology has built, we shouldn't be using the term dependence as addiction, but instead should be very explicitly referring to physical dependence to connote what is it that we are referring to, as opposed to addiction. There's been a lot of work to try to identify and understand these two phenomena. In a very simple way, I've actually have this diagram that really illustrates not only are the temporal sequence of events that lead to physical dependence, which are very fast and very frequent, very different from those that lead to addiction, which are very slow and very infrequent. But actually the neuronal systems and brain areas that are implicated in physical dependence versus addiction are quite distinct. Physical dependence predominantly reflects the effects of opioids in areas of the brain that are predominantly involved with regulating our autonomic function, that are actually located deep in the areas of the brain, on the brainstem, predominantly. On the other hand, addiction involves multiple circuits that are necessary for us to motivate our actions, to perceive pleasure and reward, to make decisions and be able to carry through those decisions and self-regulate our desires, and also that are importantly involved in our mood states and reactivity to stress. So it's a much more widespread effect that is affected when you're addicted than when you're physically dependent. So what is it that we know on physical dependence? Physical dependence actually has been shown to emerge even after one single administration of an opioid. It does not always manifest to the same extent in some individuals. Some individuals are more sensitive to physical dependence than others. At the cellular level, we understand that the neurons, which are normally when you get an opioid that binds to the mu-opioid receptor, you inhibit adenyl cyclase. And adenyl cyclase is just a chemical that signals internally in the cells. If you give it repeatedly, though, what you happen is the cell, who is always bombarded by this opioid inhibiting adenyl cyclase, actually compensates by producing more adenyl cyclase. And as long as you are on the opioid, it actually acts as a brake. But when you remove that opioid, that adenyl cyclase that was counteracting the inhibition by the opioid shoots up. And that's why what you can actually see here, if I can use this to illustrate, let me see. Yes. No, this is not very good. Guys, I am sorry to, yeah, can you see my little thing? Well, so let me move here. So you can see the cyclic AMP, and then you actually see that jumping up. So that is exactly a cellular adaptation that results in a very, very strong reaction that if it occurs in areas like the locus coeruleus, which is the main nucleus for sympathomimetic activation, it generates a sense of tremendous distress. Now, what are the good news about physical dependence? The good news about physical dependence is you can treat it by slowly weaning the patient of the opioid drug. You don't need to do more than that overall, unless it's very, very severe, in which case you can do medications to compensate for the symptoms that the patients are experiencing. What are those symptoms? Diarrhea, abdominal cramping, goosebumps, nausea and vomiting, dilated pupils, rapid heartbeat, high blood pressure. And if you've ever been given an opioid, and I was, for an accident, and I went cold turkey, I basically triggered a physical dependence on myself. And what I recall was how disagreeable it was. And it was actually much worse than the pain. And this gave me an insight, because if you do not know and you have this horrible sensation of deprivation because the drug is not there, you immediately are going to learn that if you take the opioids, that's going to make you feel better. And you may think that you are addicted. And in fact, this is what a lot of physicians, and it's not just the lay public, but the physicians themselves, many times basically confuse that a patient just has physical dependence versus having addiction. And why is that important? Because you go from a situation where what you should have done with that patient, which is wean them off slowly from their opioid medication. If the physician feels that they are addicted, they will give them a medication for an opioid use disorder, which will sustain their basically being on an opioid drug for a much longer period of time that's necessary. So physical dependence is extremely important because it actually can be quite severe, and if you do not properly manage it, it can lead the patient to seek opioid drugs by themselves. But it is very distinct from that of addiction. And when you read in the literature and says, well, patients that are being given opioid medications for pain, what percentage of them become addicted? Well, you will read that it goes from a range of less than 1% by some authors to close to half of the patients that are given an opioid will become addicted within a very short period of time. And that basically reflects the misunderstanding that we have between physical dependence and addiction. And it's extremely prevalent, and I'm going to reiterate it again, and unfortunately is leading to mistreatment and management of patients. What's the distinction with addiction? Addiction actually does not at all develop on every single patient that gets an opioid, even if it is repeated. And in fact, most patients that are treated with opioid medications properly do not become addicted. They will become physically dependent, but not addicted. In other words, you can be physically dependent and not addicted. If you're addicted, you're very likely also physically dependent. Addiction actually basically occurs predominantly in individuals that have a vulnerability. And who is vulnerable? Well, there are genetic factors that makes us vulnerable. There are also psychiatric diseases that makes us vulnerable. And another component that we're trying to understand is what the interaction of having severe pain that is not properly managed vis-a-vis the risk of becoming addicted. And again, it's not just the concept of a person that has severe pain that's not properly managed may end up committing suicide, but it is also possible that in certain instances, the mismanagement of a patient with a chronic pain can result in addiction. And not by withholding the opioids, the desire becomes so intense to relieve that pain that in and of itself can act as a reinforcer. Highlighting why, it becomes a very crucial distinction in terms of how to inform patients about what these medications do and also how to treat them. What we now know, for example, you have there the main circuits in green, red, and blue that are involved in addiction. Addiction has a cyclical nature. You actually go through the state of intoxication. Once you basically crash, you go to a state of withdrawal that then leads to the desire of more drugs, that leads you to take the drug back again and again. It connotes compulsive thinking about it and the inability to control the urges. And while it is actually, as I say, occurs in approximately 10% of patients and it takes months to develop, it persists months or sometimes years after the discontinuation of the drug. However, we're very fortunate to have medications that can be used to treat opioid addiction. And we have three main medications: methadone, buprenorphine, and naltrexone. These three medications target the mu-opioid receptor. Methadone is a full agonist. Buprenorphine is a partial agonist. That means it's less potent than methadone. And naltrexone is an antagonist. It just occupies the receptor, but it does not produce signaling inside the cell. But it interferes with drugs being taken. These three medications significantly improve outcomes. Significantly. If you're on these medications, you are 3 times less likely to die from an overdose than if you are not. You're much more likely to recover. You're much more likely to be able to go back to work, to have less of a risk for other adverse consequences from opioid use, such as infectious diseases, neonatal abstinence syndrome. But they are not being used because, again, of a total and absolute misunderstanding. In fact, I've heard many times, you are substituting one drug for the other. The person is addicted to their methadone. The person is addicted to their buprenorphine. No, they are physically dependent to the methadone. They are physically dependent to the buprenorphine, but they are not addicted to these drugs. And again, another example about why this distinction is very, very relevant. So what are the conclusions? I mean, in terms of a summary, physical dependence is treated by slowly tapering of the opioid drugs and results within days. Most people treated with opioids for pain will have physical dependence. That does not mean that they are addicted. On the other hand, if you are addicted to an opioid, that is actually significantly improved with the management of medications. Because it is a chronic disease, these medications may be required for months and sometimes years. Or as you are being treated with these medications, if it's methadone and buprenorphine, you will have physical dependence. But that in and of itself should not interfere with the outcomes. And because of all of these issues, in terms of implications for the management of the patient and its outcome, whether it's a patient with pain or a patient with an opioid use disorder, it is fundamental that we actually help train physicians on the distinction between physical dependence and addiction. Thanks very much for your attention.